Welcome to NCLEX RN Review, produced by Nursing Tutorial and Consulting Services. This DVD is on cardiovascular. I'm Judy Miller, and I will be your guide. This segment is on assessment. As we start to talk about assessment in the cardiovascular system, I think it would be a good idea for us to look at just a little bit of the anatomy, if you will, of the heart. If A, in this diagram, is the superior vena cava, what is B? That's right, B then is the inferior vena cava, and both of these empty into which chamber of the heart? That's correct, it is the right atrium, which is letter C. Then the blood passes through this valve, which is letter D. And which valve is that? That's right, the tricuspid valve, into chamber E, which is the right ventricle. Blood then passes out through F up here, which is the pulmonic valve, out through the pulmonary arteries, which are G in this picture. Now remember that the pulmonary artery is the only artery in the non-fetal circulation that carries unoxygenated blood. Arteries, by definition, go away from the heart. And of course, the pulmonary artery carries unoxygenated blood away from the heart toward the lungs so it can be oxygenated. And of course, that pulmonary artery divides into two branches, the right and the left. Now, the blood gets oxygenated in the lungs and comes back then to the heart through these structures H, there's 4 of them, 2 on each side, and these are called, that's right, the pulmonary veins. The pulmonary veins are the only veins in the non-fetal circulation that carry oxygenated blood. Veins, by definition, go toward the heart. So these pulmonary veins enter into which chamber? That's right, the left atrium, which is chamber I in this picture. They enter in the back of that chamber. And then the blood goes through J, which is which valve? That's right, that's a mitral valve or the bicuspid valve, into chamber K, which is the left ventricle. And that, of course, pumps blood out through L, which is the aortic valve, and out through the aorta, structure M here, all the way out to the rest of the body. And that's a quick view of the circulation of the heart. And that's important to keep in mind as we start thinking about the heart. Now, I thought I would just show you a quick picture here, one of my favorite views of the heart. I like this one because it does show the valves, so you can see the valves in here. So you see the tricuspid and the bicuspid, and then you can see the pulmonic valve and the aortic valve. So I kind of like that picture of the heart as well. Now I want us to talk about some more tests, and as we look at some other tests, these are blood tests. The sedimentation rate and the C-reactive protein are tests that indicate inflammation somewhere in the body. So when we see an elevated sedimentation rate, we could see it in very diverse conditions. You could see it in things as diverse as rheumatic fever, rheumatoid arthritis. So it's lupus, for instance. So it just says there's some inflammation somewhere in the body. Now CRP, or C-reactive protein, doctors are getting very excited about, because some of the research suggests that an elevated CRP is probably as good an indicator of heart attack risk as elevated cholesterol. And the thought behind this is that the elevated CRP indicates inflammation of the blood vessels, and this then, of course, predisposes the person to clot formation and heart attacks. Another test that we probably want to look at, the cardiac markers we're going to pull out in detail, the lipids and the clotting studies we're going to look at in much more detail. So let's move on and look at the cardiac markers. I'm not sure for NCLEX that you have to memorize all of these numbers, but I thought I would give them to you. The CPK, total creatinine phosphokinase, normal range is in the 30 to 200 units per liter. CPK, particularly the MB band or the MB fraction, this is a very important one because this is the part of CPK that tends to rise with an MI. The other total CPK could rise with everything from liver disease, skeletal muscle problems, but the MB band is more unique to heart attack. And again, with the MB fraction as being a percent of the total CPK. I'm not aware for sure that the fraction has been on NCLEX, but it's probably a nice piece of information to have. The troponin I and troponin T are tests that have been around for several years now, but are fairly specific to cardiac muscle. So if a patient comes in with symptoms of a heart attack, with the chest pain, shortness of breath, etc., and an elevated troponin level, they're going to be admitted to the coronary care unit because this is highly suggestive of a possible heart attack. Now, as far as those enzymes or cardiac markers are concerned, these are based on the idea that when there's heart damage, these substances rise. It creates changes in the chemistry, and there will be an elevation in these substances. As I said before, some of these enzymes will also elevate with liver disease and skeletal muscle disease. So we have to look at the patient in totality. I think we should also think about cholesterol levels. When we think about cholesterol, total cholesterol, it contains the HDL, the high density lipids, plus, which are the good ones actually, the healthy ones, plus the LDL, the low density lipids, these are the lousy ones, plus the triglycerides divided by 5. So total cholesterol is more than just HDL and LDL. There's a special formula to it. As you saw on the slide, there's a little formula for LDL. I'm not aware that you have to know that for NCLEX, but people ask me frequently, so I put that up there. There are, if you take a look at that picture down there, and you see this blood vessel here, the LDL, the low density lipids, actually bring the fat and the atherosclerotic plaques and all in and line the blood vessels. So that's why I call the LDL the lousy one. The HDL, the high density lipids, take the fat out of the blood vessels. And that's why I call these the healthy ones. Now there are a few guidelines, and these are indeed just guidelines that many physicians follow. If your LDL is above 100, you should have an HDL of at least 45. If your LDL is above 140 or it's above 100 and your HDL is below 45, you should be on a low-fat diet, and many of these patients will also be on anti-cholesterol medications. Let's look at some specific numbers here. These numbers you should probably know. Total cholesterol should be less than 200 milligrams per deciliter. LDL should be less than 100. And the HDL, for women it ought to be 50 to 60, for men in the 40 to 50 milligram per deciliter range. Triglycerides we'd like to keep less than 150. So these numbers could actually show up in test items for you. Now there's some more tests that I think we should know, some more numbers, if you will. And these are clotting studies. So if we think about these clotting studies, prothrombin time, or sometimes called PT, some people even call it pro time, the normal PT is around 11 to 15 seconds. Now when we're thinking about clotting studies, I want us to think two ways. One, if you had a question about a preoperative patient who is getting clotting studies, you would want the normal values. So when we're looking for that kind of situation, you hope the patient has normal values. We are going to look at some of the clotting studies as they relate to the management of heart disease, particularly for patients on anticoagulants. So we're going to add another little twist to that. So we said that the prothrombin time is normally 11 to 15 seconds. If this was being done for a preoperative patient, one would hope then that their value was in the 11 to 15 second range. If, however, the test was being done in a patient who is on Coumadin therapy, we would hope that the PT level was 2 to 2.5 times the control or the known normal. Now, because when a patient is on Coumadin therapy, the purpose of Coumadin therapy is to make it take longer for the blood to clot. So we hope that it's going to take twice as long. It's going to be 2.5 times the normal. Now, sometimes Coumadin or the clotting results are in terms of INR. And so when we look at the INR, if the patient is on Coumadin therapy, the goal is 2 to 3. Now, this is a ratio. INR stands for International Normalized Ratio. And so we hope it would be 2 to 3 times the normal. So it would take 2 to 3 times the usual length of time for the blood to clot. Many labs will give you the INR. Some will give you both. Some patients who are regulated on Coumadin or warfarin therapy, the doctor will want one or both of these studies to be done. Another test, clotting study, is the PTT, partial thromboplastin time. The normal of that is about 60 to 70 seconds. There is also a test called the APTT, activated partial thromboplastin time, which is done a little more quickly. That's 30 to 40 seconds. Now, this test is used to monitor patients who are on heparin therapy. So if they are on heparin therapy, we would monitor that test, and we hope that it would be 1.5 to 3 times the control or known normal. Now, I want you might say, what in the world does PTT equal H mean? So if you take a look at my fingers here, you can see that if you put 2 lowercase t's side by side, they kind of look like an H. So that little PTT equals H is simply a memory tool for you to tell you that the TT part, the thromboplastin time, reminds you that this is the test used to monitor the effectiveness of heparin therapy. Because oftentimes the exam will ask you, which test do you expect to monitor depending on which anticoagulant the patient is on. Now, there's one more anticoagulant or clotting study that I really want to just mention. We don't do this as much as we once did, but once in a while it tends to show up in test items. And this is the clotting time or coagulation time. Sometimes it's even been called the Lee-White clotting time. In this test, blood is simply put in a tube with no chemicals in it and left to see how quickly it clots. Now, for most people, it's going to take about 10 minutes or so for the blood to clot. So that 5 to 15 minute range. If the patient is on heparin therapy, we would expect that it would take about 20 minutes for the blood to clot. You are caring for a patient who is receiving warfarin or Coumadin. Before you administer today's dose of Coumadin, you want to check the patient's prothrombin time levels. So you look at the lab report, and these were the patient's PT levels. The patient is 24 seconds and the control is 12 seconds. So my question for you is, will you administer the Coumadin? Yes, you'll administer the Coumadin because this is exactly where you want it to be. The patient is double the control or the known normal, and that is the goal. When the patient is on Coumadin, warfarin, or Coumadin being the trade name therapy, the goal is that they will be about double the known value. Now, you are taking care of another patient, also on warfarin or Coumadin, and this patient's PT is 50 seconds, and the control or no normal is 12 seconds. So my question for you is, will you give this patient the Coumadin as ordered? And the answer is no. You're going to hold this and check with the physician. This is more than 4 times the normal value. This is too far out of range. In fact, you might ask the patient if his gums bled when he brushed his teeth this morning, if he's got any blood in his urine or stool. You are caring for another patient, also on warfarin, and this time it's the INR value you're looking at, and this INR is 2.5. So my question is, will you give this patient the Coumadin as ordered? And the answer is yes. The goal is that the INR in most patients, your goal will be 2 to 3. And this is right exactly in the middle. It's right where you want it to be. So go ahead and administer the Coumadin to this patient because that INR is right on target. Now you have another patient also receiving Coumadin, and this patient's INR is 6.5. Will you administer the Coumadin to this patient? And the answer is no. This is way, way out of range. With most patients on Coumadin, the goal for the INR is 2 to 3. And this is 6.5. You better check the patient for bleeding. Are there any bruises on their body? Did they have any blood in their urine, their stool, their gums bleeding, etc.? Because this one is way out of line. All right, that's important. I think it's very possible you could have questions relating to the administration of Coumadin on NCLEX. Let's do a question. A patient who is receiving warfarin or Coumadin 4 milligrams daily has an INR of 5.9. What should the nurse do at this time? 1. Administer the medication as ordered. 2. Hold the medication and call the physician. 3. Call the physician after administering medication. Or 4. Ask the patient if he is feeling all right. So at this time is when you've gotten that result of an INR of 5.9. So the best answer here is number 2, hold the medication and call the physician. This 5.9 is way out of line. Your goal is undoubtedly between 2 and 3. We're going to look at another test. We're going to talk about the stress test. This is essentially an ECG, electrocardiogram, done during exercise. Many patients can have a normal resting ECG, but when they exercise, there may be signs of ischemia. So the preparation for this is quite simple. We don't want them to have a whole big heavy meal for 4 hours before. We don't want a lot of stimulants before or after. So your patient might be able to have a little juice and toast for breakfast, but you don't want them to have bacon and sausage and pancakes and coffee because you don't want the coffee stimulant, the caffeine, and you don't want a big heavy meal. Now, we also don't want a lot of smoking before and after. Of course, nicotine is a vasoconstrictor. Now, the reason we don't want the heavy meals is that when you eat a big heavy meal, that is going to require your heart to pump a lot of blood to the GI tract. So we don't want to put that kind of stress on the system with that. And of course, stimulants will increase the heart rate. Now, with a stress test, the patient comes in, gets hooked up to the ECG monitor. They get on a little baseline strip. They put them on, usually it's a treadmill, could be an exercise bike, but usually a treadmill. And they increase the incline and the speed with which they're running until they either reach their target heart rate or the patient says, oh, I've had enough. In any event, during the entire time, their ECG is being monitored. If there's any indication of trouble, of course, it would be stopped. But this can often give a sign of ischemia when the heart is under stress or working very hard. An alternative to this, or I shouldn't say an alternative, an additional study that can be done beyond this is really a thallium stress test. With the thallium stress test, the preparation is a little more severe, if you will. The caffeine fast is usually 24 hours. Usually the patient is MPO after midnight because they'll be getting a radioisotope. And no smoking, usually at least since midnight, and sometimes they want a 24-hour no smoking. The procedure goes like this. They come into the cath lab, an IV line is established, and thallium is injected. They then get a baseline heart scan, so they go into a scanning machine. Looks something like a CAT scanner, but they go into a scanning machine, get a baseline heart scan, then they're put on the treadmill. They do their exercise piece just like they would with the other treadmill, hooked up to an ECG and all. And then following that, they go right back into the heart scanner and get a repeat heart scan. And this scan, that being lit up with the thallium or the radioisotope, allows for a better look to see if there's any evidence of ischemia in the blood vessels and in the heart muscle. Another test I want us to look at is cardiac cath. This has, for some reason, been a very frequent flyer on NCLEX. The purpose of cardiac cath, there are several of them. We can determine oxygen levels in chambers of the heart, cardiac output, blood flow, pulmonary blood flow, and we can also take a good look at coronary arteries. So as we look at the different approaches, we'll pull out which one is used for which purpose. In a right heart catheterization, a venous approach is used. The catheter is put in usually the femoral vein, occasionally antecubital, but usually femoral vein, and winds through the vena cava up into the right atrium. Now, in the right atrium, you can measure oxygen levels. If, for instance, the oxygen level was higher than normal in the right atrium, that might suggest an atrial septal defect, that there was a hole between the left and right atria, and oxygenated blood from the left side of the heart was going to the right. Now, the catheter then can go through the tricuspid valve into the right ventricle, again measuring oxygen levels in the right ventricle. If it's too high, again that might suggest a VSD, a ventricular septal defect. The catheter can then go into the pulmonary artery where blood flow, pulmonary blood flow can be measured. So you can see that the right heart cath can really pick up, for instance, heart defects, holes in the heart, pulmonic stenosis, so it can pick up that kind of thing. Now, a left heart catheterization, the catheter is put into an artery. This is the arterial approach. The left side of the heart is considered the arterial side. Usually the catheter goes into the femoral artery in the groin, but it could go into the brachial artery in the arm. Now, with a left heart catheterization, it goes then through the aorta and into the left ventricle. Dye is usually released at this point, and you can watch the left ventricle fill up. And then the blood, of course, will go out through the aortic valve into the coronary, off the aorta into the coronary arteries. And you can visualize the coronary arteries. This is a test that's often done when we suspect someone might have a heart attack. And this can tell you which vessels, which coronary arteries are blocked. So the left heart cath is more frequently done for people who we suspect have coronary artery disease. Now, there are some things we need to think about in terms of nursing care. Before the procedure, we have to ask the question, that iodine question of the patient, are you allergic to shellfish? Because the dye that's being used is usually iodine. You would need baseline vital signs. Usually we have the patient empty their bladder. They might be sedated during the procedure, not always, but they may be, but they are not going to be put to sleep. So they may have some sedative, but not anesthesia. Usually distal pulses are marked because in the following the procedure, we'll have to be monitoring distal pulses and pedal pulses, and you know how hard they are to find sometimes. So you might be asked to monitor those or check those before the procedure. Now, after the procedure, whenever you've entered into a large vessel, there are two things that we're most concerned about. There could be bleeding at the puncture site. So you need to assess the puncture site for hematoma formation or evidence of bleeding. The other big issue is that a clot could form inside the blood vessel. If actually it has to seal off, but you could get too big a clot forming inside the blood vessel. And then you could get obstruction of circulation distal to that point. So you need to monitor pulses distal to the insertion site. You need to check the extremities for color, temperature, tingling, for any evidence of circulatory impairment. Now the patient will also have this ECG being monitored in the post-procedure time, as well as the rest of his vital signs. So let's do a question. A 56-year-old is to have a cardiac catheterization tomorrow. While he is filling out his menu, he says to the nurse, "I always get a rash when I eat shellfish. What is the most appropriate initial nursing intervention?" 1. Notify the physician. 2. Place a note on the chart about this reaction. 3. Ask him if he is also allergic to tomatoes. Or 4. Notify the dietitian and request a no shellfish diet. And the correct answer is number 1. Now, if you notice the data that he has this allergy to shellfish or a rash for shellfish, and his procedure is to be done tomorrow. So you need to notify the physician, let them know of the possible allergic reaction. The physician needs to make the decision. The decision might be to cancel the procedure. It might be to give him some steroids and Benadryl to make the procedure safer. Like there may be in some places an alternate dye that might be able to be used. Let's look at another question. An adult returned from the cardiac catheterization lab where he had a right and left-sided heart catheterization. He is lying quietly in bed. The nurse checks his vital signs and the groin catheter insertion site. The client says he is going to read and begins to raise the head of the bed. What is the best initial nursing action? 1. Explain that he must not move his leg for 12 hours. 2. Elevate his affected leg on a pillow. 3. Check the peripheral pulses in the affected leg. Or 4. Explain that the head of the bed should not be elevated because the groin site must be kept straight. And the correct answer is number 4. Now let's take a look at the question and see the problem. The problem behavior in the question is the client begins to raise the head of the bed. So, should he raise the head of the bed and bend his catheter insertion site? The answer is no. So the answer relates to the problem behavior. See how it relates directly to that problem behavior. Now, there is another answer that has some truth to it, and that is answer number 3, and you certainly will do that. But when there is a very specific problem behavior, your initial action would relate to that. In this case, it's very much of a safety issue. So that's a little bit tricky in that question, but I want you to note to look at the problem behavior in the question and then make sure your answer relates to that problem behavior. Let's do another one. The nurse is caring for an adult who just returned from the cardiac cath lab where a left-sided heart catheterization was performed. The nurse observes all of the following. Which is the greatest cause for concern? The patient has a pulse of 78 beats per minute. The patient is drinking cranberry juice. The patient is sitting upright on the bedpan, or the patient's blood pressure is 136/86. The greatest cause for concern is answer number 3. The patient is sitting upright on the bed pad, because that means that that catheter, groin catheter insertion site is being bent, and that could cause bleeding. We don't want to do that. The other choices were all acceptable actions. Now, how long does that catheter insertion site, that groin catheter site, need to be kept straight? This varies a bit from hospital to hospital. Most places are somewhere around 4 hours, but I've seen it anywhere up to 6 or 8 hours, so it will vary. But undoubtedly, that first 2 to 4 hours are the most critical time for keeping that groin catheter site from being bent very much. One more test I want us to talk about, and this is Swan-Ganz monitoring, or they might refer to this as a balloon-tipped pulmonary artery catheter. Now, I am not sure that they'll ask you about all the insertion process with that. Usually the physician is going to do that. But I think you should note that this catheter will go, it goes through the right atrium, into the right ventricle, and on out into the pulmonary artery. Now the distal port, at the distal port opening, we can measure pulmonary artery pressure. We can also get pulmonary capillary wedge pressure. There's a little balloon there that can be blown up. Now at the proximal port, what you're measuring here is right atrial pressure. So the advantage to this type of device is you can get venous pressure, which is right atrial pressure, and then also your pulmonary capillary wedge pressure. So you can pick up both left-sided heart failure and right-sided heart failure. So let's look at a question. An adult was admitted to the coronary care unit following a myocardial infarction. A balloon-tipped pulmonary artery catheter was inserted when the client began to exhibit signs of cardiogenic shock. The nurse measures the client's pulmonary capillary wedge pressure and finds it to be 18 millimeters of mercury. The nurse knows this pressure is less than normal, normal, higher than normal, or life-threatening. And the best answer here is number 3. It is higher than normal. So let's look at what the normals are. The normals for pulmonary capillary wedge pressure are in the 4 to 12 millimeters of mercury, with greater than 15 being considered really abnormal. And in this question, it was 18. Above 20 would be considered life-threatening. Now, this slide also shows us central venous pressure and intracranial pressure numbers as well. Notice that all of them are abnormal when they get to be greater than 15. Now we're going to do another question. The nurse routinely obtains a client's central venous pressure readings. Based on the values obtained, the goal for subsequent interventions is to initiate activities designed to 1. Maintain a normal range of pressure in the right atrium. 2. Lessen the pressure in the pulmonary artery. 3. Detect dysrhythmias in the left ventricle. Or 4. Promote circulation in the aorta. And the correct answer is number 1. Maintain a normal range of pressure in the right atrium. Look at what the question says. Central venous pressure reading. Central venous pressure is right atrial pressure. Now, to me, this question sounds rather silly, but I'd like to give you a few questions so that you maybe get ready for the kinds of questions that you might see